Good morning, everyone. My name is Lynette Roach. I'm with Black Health Matters. I'm the Media Relations Director, and I'm here to host the session on breast cancer in women of color. Besides skin cancer, breast cancer is the most commonly diagnosed cancer among American women. In women under 45, breast cancer is more common in African American women than in white women. According to Breast Cancer Prevention Partners, African American women have a 31% breast cancer mortality rate, the highest of any US racial or ethnic group. Let that sink in for a second. These are startling statistics, and to help us understand more about this topic, we are pleased to welcome Dr. Janeen Azare. Janeen Azare, PhD and MSPH, is a native of Southwest Louisiana, where she grew up very interested in learning more about what had become all too familiar to many, the infamous Louisiana corridor known as Cancer Alley. Curiosity fueled her desire to make a contribution to the science of cancer by conducting research focused on analyzing proteins that contribute to the progression of breast and prostate cancer. Dr. Azare now continues her efforts as an oncology senior field medical director, breast cancer at Pfizer Oncology, where she leads the team's initiatives on research services, diversity in clinical trials, disparities in healthcare, and patient advocacy. Please join me in welcoming Dr. Janeen Azare.
Thank you, Lynette, for the warm introduction. And I would like to thank Rosalind and the Black Health Matters Village for having me present this morning. The changing demographics in the US are becoming all too familiar to us. By the year 2045, racial minority groups will make up the majority of the US population. Black Americans account for roughly 13% of the US population, but make up only 4% of oncology, which is cancer, clinical participants. Unless a clinical trial includes a type of people who have the particular condition, let's say breast cancer, in the general population, the results may not be meaningful to all those who have breast cancer. Let's take a look at metastatic breast cancer in the US. Up to 30% of early breast cancer can develop into metastatic breast cancer. Women in the US have a 1 in 8, which is about 13% lifetime risk of getting breast cancer. This means for every 8 women in the US, 1 will be diagnosed with breast cancer during her lifetime. This also means there is 7 in 8, about 88% chance she will never have breast cancer. Approximately 168,000 women are actually living with breast cancer. The 5-year survival rate following a de novo metastatic breast cancer diagnosis is 33%. De novo metastatic means that the cancer in the breast wasn't detected before it started to spread to other parts of the body. Breast cancer is the most common diagnosed cancer in Black women, making up 32% of new cases. Breast cancer accounts for the second largest number of cancer deaths among Black women at 18%. Breast cancer is the most diagnosed cancer also in Hispanic women, making up 29% of new cases. Breast cancer accounts for the largest number of cancer deaths among Hispanic women at 16%. Let's take a look at stage at diagnosis and survival. Stage of disease describes the extent of spread of cancer at the time of diagnosis. In situ is referred to as stage 0. Local stage, stage 1. Cancer that's diagnosed at a regional stage is considered stage 2, and it also can be considered as stage 3. Distant stage is stage 4. In general, treatment is less likely to be effective the further a cancer has spread. Blacks are more likely than whites to be diagnosed with a more advanced stage of cancer, which is usually stage 3 or stage 4. About 85% of breast cancer occurs in women who have no family history of breast cancer. The risk of developing a breast cancer increases in all women as we get older, but Black women are more likely to be diagnosed with breast cancer at a younger age compared to white women. The median age at diagnosis is 62, 59 for Black women compared to 63 for white women. In women younger than 40 to 45 years old, the population incidence rate of breast cancer are higher in Black women compared to white women. About 30% of all newly diagnosed Black breast cancer patients are younger than 50 years of age, compared to only 20% of white patients. Black non-Hispanic women have a 7% lower risk of cancer diagnosis than white non-Hispanic women, but a 13% higher risk of cancer death. Despite slightly lower incidence rates for breast cancer, Black non-Hispanics have a death rate of about 40 to 41% higher than white non-Hispanic women. Rates were higher in the Black non-Hispanic women than the white non-Hispanic women in about 8 other states from the SEER data bank. Since the late 1990s, breast cancer rates dropped about 26% in Black non-Hispanic women, compared to 40% in white non-Hispanic women. This racial disparities is largely due to advanced stage at diagnosis, higher prevalence of obesity, comorbidities, and other tumor characteristics, and also lack of access and adherence to high quality cancer treatment. Only about half, about 56% of breast cancer in Black women are diagnosed at a local stage, which is stage 1, compared to 66% in white women. That's a 10% difference. So stage 1 has a 5-year relative survival rate, which is very promising at 98.8%. So if you shift your attention a little bit to the stage 4, the distant, there's a 3% difference with 8% for Black non-Hispanic women compared to 5% for white non-Hispanic women. So the more advanced stage you are at a diagnosis among Black women has been largely attributed to issues that are also related to access to high quality care, fewer mammograms, and maybe even lack of follow-up if there's like an abnormal result. Thus, early detection is definitely warranted. A common measure for cancer survival is relative survival. The overall 5-year relative survival rate among Blacks has improved from the early 60s at 27% to 63% now in the mid-2000s. However, still, Blacks continue to have a lower 5-year survival than whites. Most of these differences are also attributed to socioeconomic barriers, limited access to timely and appropriate high-quality health care. Differences in tumor characteristics can also contribute to these disparities in some cancers. And again, earlier screening for Black women is warranted. Let's take a look at male chest cancer in the US. There's less than 2,700 new cases of male chest cancer, with an estimated 15% of those ending with a risk of death. Breast cancer in men accounts for less than 1% of all breast cancer cases. Men in the US have 1 in 833, which is about 0.1% lifetime risk of getting breast cancer. So that's really, really pretty small. The 5-year survival rate is 84%. To date, little research has been done on male breast cancer. However, that is all changing because of so many international research groups that are now looking at male breast cancer. So the stage of diagnosis and survival is very similar to that of women in terms of local, regional, and distant. Age is also a primary risk factor in breast cancer for men, and it's also a risk factor for women. The median age of diagnosis is 68, which is on average about 5 to 10 years later than women. As with breast cancer in women, a family history of breast cancer and mutations in the BRCA gene 1, and especially the BRCA2 gene, are also linked to higher incidence in breast cancer in men. So BRCA testing is recommended. Most men with breast cancer are diagnosed after finding a lump or a mass. A lump or a mass doesn't mean you have breast cancer, but it should be evaluated by a physician. Breast cancer in men tend to be diagnosed at a more advanced stage than it is in women. Men tend to have symptoms, but they may discount these symptoms and may take longer to see a doctor. The tests that are used for male breast cancer diagnosis is very similar to those for women in terms of mammograms. The 5-year relative survival rate for men at the regional level and the localized level is less because it's the localized level is not as often diagnosed. Blacks are more likely than whites to be diagnosed with cancer at a regional or a distant stage of breast cancer. Black non-Hispanic men are 50% more likely to be diagnosed with breast cancer than white non-Hispanic men and have a 66% higher risk of death. In older people, there's also disparities. Older people with metastatic breast cancer, younger women have a higher survival rate than older women, and white women have a higher survival rate than Black women at both age groups that are shown here. I would like to take a moment to address why in the presentation you're seeing incidence, survival, mortality data that seems very old from 2017, 2016. Projections are made regarding new cases and deaths in order to get the cancer burden. There's usually a 3 to 5 year lag in data, but the trends that are presented are most current. And in this presentation, it doesn't mean that the data that you're looking at is old. It just simply means that it took time to carefully collect the data, do the analysis, and prepare the findings. Now let's shift gears to the importance of diversity in cancer clinical trial participation. I mentioned earlier that Black and other racial ethnic minorities are underrepresented in clinical trials, which makes it even more difficult to assess efficacy of cancer therapies among these groups. Diversity representation in clinical trials simply allows for us to gain insights necessary to make medicines that will be most effective for all. It defines good science and better medicine. Here's a drug trial snapshot of all drugs from 2019. There was a total of 48 drugs that were approved. The demographics show the commonly underrepresented subgroups. As you can see here, there were 9% Black participants compared to 72% white participants, 18 for Hispanics, and 72 for women, and those aged 65 and older was 36. So why am I showing you this? Because in this next slide, we're going to take a look at oncology drug snapshot. There were 11 drugs that were approved. The demographics changed. There was a 5% decrease for Black participants, going from 9 to 5, compared to a 1% decrease, going from 72 to 73 for white women participants. The Hispanic subgroup decreased by 13%, going from 18 to 5. And the women's group decreased by 38%, going from 72 to 34. And those aged 65 and older decreased by 6%, going from 65 to 59. So as you can see here, there are disparities among these subgroups. I would be remiss if I didn't mention the historical record of experimentation on Blacks that still lingers on the fears of being experimented on. The Tuskegee syphilis study and the case of Henrietta Lacks. The importance of knowing about these two studies is not to only acknowledge wrongdoings, but to also remind everyone that clinical trial participants are volunteers. There have been many safeguards to clinical trial participation that have been put into place to protect patients. These safeguards cover ethical issues and review of policies and protocols to ensure that all research participants are protected. In addition to the historical distrust, there is a lack of knowledge and awareness, a lack of access, that are additional barriers to clinical trial participation. However, there are potential solutions to address these. Some of these include educating on biases and diversity, Pfizer has an investigator training program, which is conducted at clinical trial sites before studies are open. I know we speak very often of awareness, but it's very important to provide education, outreach in the community, and support on finding clinical trials, and have materials that are accessible and available for these efforts. Placing clinical trials in areas where there's a need is of utmost importance. Pfizer is committed to ensuring that our clinical trial populations reflect the racial and ethnic diversity of countries where we're conducting our clinical trials that we intend to treat or prevent. From a biological standpoint, having a diversity in clinical trials allows for us to understand the differences in outcomes to help ensure the safety of therapies, to better understand the role of biology in cancer treatment, and also to help address the healthcare disparities in sex, age, race, and ethnic backgrounds. So there is a call to action. So how can you help? As I've mentioned before, participation in a clinical trial is voluntary. Thus, the call to action is to have each of you take a few pearls from this presentation that I'm presenting to become better informed about disparities in breast cancer and clinical trial participation. This Black Health Matters Winter Summit is dedicated to improving health outcomes in our communities. Thus, I hope this presentation helps you to start the conversation with your physician. Thank you, and I will go ahead and take questions. So in the chat group, so the first comment is, there is a population of men who have also been diagnosed with breast cancer. Do you think this could be transmitted genetically, from maternal, or genetically paternal? Is there a possibility that a father could transmit a genetic to his daughter? So the answer to this, there's the BRCA gene, the BRCA1 and the BRCA2. Both are hereditary in nature. So they can either come from the mother or from the father. What is the probability the cancer will return? So the earlier you catch the diagnosis of breast cancer in men or women, your relative survival rate is better. If it's an early breast cancer, you have a chance of it developing to metastatic breast cancer. But with treatment, mastectomies, radiation, and various therapies, you can reduce your risk of recurrence, especially for early stage breast cancer, stages 1 and 2. But they can also recur. If someone had stage 0 breast cancer 5 years ago, how likely is it to come back? It really depends. During in situ stage 0, they remove all of the tissue and try to get all of the cells out. But just the nature of our bodies, you can recur. So it just really depends. Another question is, good morning. If you had a skin cancer on a mole on your breast, is this something that you can come back once removed? Does this mean you could get or have breast cancer lumps? So moles are related to either benign or they could be malignant in terms of melanoma. However, removing them, they could possibly not reoccur or reoccur. But the link from that to breast cancer, I'm not sure what that link is, but breast cancer on its own has different symptoms and characteristics that may not be linked to having a mole. So what I definitely suggest is keep your eye on any changes to the breast, and if there's dimpling, inverted nipples, redness, swelling, definitely have that checked out by a physician. What are some things that I can do to limit my chance of getting breast cancer? A few things that you can do is get your annual mammograms, exercise, have a healthy diet. Another question is, how do I find clinical trials to which there is compensation? It seems like this would be provided more, they would provide more incentive to participate. Some trials require a time commitment. Time is money. So the definitive place to find a clinical trial is clinicaltrials.gov. Also, Pfizer has a website, also Pfizer Clinical Trials, where you can find Pfizer clinical trials. At Pfizer, some clinical trials do have a compensation part to them in the sense of transportation and meals and parking. And most other companies may also do this as well. And also you can reach out to various patient advocacy groups that have various grants to help and aid with this. Another question is, what does it mean when the doctor says you have dense breasts? What that means is that all our breasts have fibrotic tissue through them. So it just means that you have more fibrotic tissue than, say, someone that doesn't. Also, a woman that is premenopausal, meaning she still has her menstrual cycle and she's younger, may have more of a dense breast. Also, Black women have more of a dense breast than white women. And so what I want to say about that as well, so women with dense breasts, when we're having our mammograms, sometimes that can interfere with how the mammogram shows up. So sometimes they recommend you have an ultrasound done as well. What would you say is the best way to get patients and doctors to move forward with respect in getting Black patients involved in clinical trials? I think it starts at the conversation of understanding diversity, biases, conscious and unconscious, asking the right questions, having those conversations in terms of participating in a clinical trial, what it means if I participate in a clinical trial, is it right for me? Again, clinical trials are all voluntary, but just starting the conversation is a place to start. Explain the difference between metastatics versus reoccurrence. Metastatic simply means the spread. Recurrence means you've had it before and it can come back. How do you find out about local clinical trials? I just answered that, but again, the definitive site for that is clinicaltrials.gov, And Pfizer also has a clinical trial website where you can find Pfizer clinical trials, which is pfizerclinicaltrials.com. I'm a metastatic breast cancer patient. It moves to my stomach lining, have ascites. Is there a trial for this? I'm not sure, but you can take a look at the clinicaltrials.gov website. Another question, what information can you share regarding triple negative breast cancer stage 2? In general, triple negative breast cancer is a more aggressive form because it happens in usually younger patients that have more dense breasts. Again, the stages of cancer, it's stage 1, 2, 3, and 4. So stage 2 simply means that it's still in a regional level, meaning it's moved to maybe the lymph nodes, but it hasn't gone to other organs within the body. I had a breast removed 8 years ago, later diagnosed with a tumor on the chest wall of mastectomy. I'm not sure what the question is there. Should we avoid certain foods as we can lower the chances of getting breast cancer? So actually, that's a good question. So there's been research that's shown a low-carb diet, a vegan diet, a vegetarian diet, a paleo diet are all good options. And also reducing your alcohol intake also helps reduce your risk. Another question, years ago, I was told no cancer recurrence after 5 years, meaning that you were free of the cancer. That's a good indication. Usually after 5 years, if the cancer doesn't come back, the likelihood of it's coming back is smaller. Great presentation. Question. It seems to me that when there is a strong family history of breast cancer, Black patients are not referred to genetic counseling at the same rate that white women, white counterparts are. This prevents the patient and other family members from being proactive in the care. Do you have any comments on how does this, a patient, know when he or she should refer to a genetic counselor so the patient can be an advocate for him or herself? Yes. So if you are a family member of someone that has breast cancer, you should have genetic testing done. And you should also have your mammograms done. So for instance, if the average age of having the mammogram is at age 40, if you have a genetic predisposition to it, meaning a family member also had breast cancer, you should get your mammograms done 5 to 10 years earlier. So if your family member is diagnosed at 45, you should start at age 30 or 35. So 10 years and 5 years. And then you should also request the genetic testing. So there is some conversation around genetic testing. So definitely have that conversation with your physician. But once again, you start the conversation, you are your best advocate to ask these questions with your physicians. Have deodorants that antiperspirant products have been linked to breast cancer? There was a study done that did link some of the heavy metal that's in deodorants to breast cancer, but now the percent of heavy metals in deodorants are very minimal. So that link is a little bit less. Exercising during treatment is so difficult due to fatigue. What suggestions do you have for reducing obesity? I know there's a lot of fatigue doing that. So something as yoga is a nice way to start with slow movement. Meditation, start there also to kind of get your body prepared. And then if possible, you can do just, small walks from, say, one end of your house to the next. Do that like 2 or 3 times. As long as you're getting the body movement, it's helpful. Once diagnosed with breast cancer at stage 1, other than chemo or radiation, what can I do to prevent cancer from returning? Again, exercising, cutting back on limited alcohol intake, eating a healthier diet, such as a vegan diet, a paleo diet, a low carb diet, lots of vegetables. Why don't primary doctors know more about clinical trials and discuss these options with women and patients? Sometimes a primary doctor will be informed, especially if they know their patient, but it's also your OBGYNs that may also have more information since this is related to breast cancer. But just in general, all doctors are aware of clinical trials for each of their particular specialties. So again, I would recommend having that conversation, asking, am I a candidate for a clinical trial based on whatever the cancer or other disease that you may have? And that's part of the training that we're trying to do, is to have our physicians be better informed, to speak more engaging with patients. Does taking hormones play a part in getting breast cancer? They can, but it depends on how your body reacts to the additional hormones. Because some women, once they go through menopause, they tend to take progesterone and estrogen to help with hot flashes and regulate the body. So there's a limit time in terms of which you take that, usually about 5 years, to reduce your chances of getting cancer. But some of them can lead to an increased risk. It doesn't mean you're going to get cancer, but it increases the risk of the possibility of getting it. Do you recommend 3D imaging? And if so, when and under what circumstances, since insurance often doesn't cover this? I think it depends. Usually mammogram is your first choice, and then it goes into an ultrasound. How do we incentivize oncologists to be more culturally competent, so that they are comfortable having the conversation with Black cancer patients about clinical trials and other clinical topics? I think with everything that is happening right now that we're seeing before us with Black Lives Matter, Black Health Matters as well. And so I think all of this is coming to the forefront, and people and physicians are becoming more astute to the diversities that we're seeing. So I think having the conversation with the doctor, asking, what are my risk factors as an African-American woman or a Hispanic woman or a person of color? Sometimes it may call for us to address our own biases and unconscious biases, because they also, as physicians, may have them as well. So it's definitely a conversation of meeting each other in the middle and having this conversation. I had a biopsy last time. It was benign, and I'm 63. How often should I have another mammogram to stay on top of everything? Usually mammograms are recommended yearly, so I would stay on top of them yearly. I would also do your self-exams. Self-exams at your age, you should do them once a month. Pick a date at the beginning of the month, at the end of the month. And you're checking for anything that looks different, feels different, any swelling, like an inverted nipple or any dimpling to the breast. If you had dense breast tissue, should you receive mammograms more often? Not that you should receive them more often. You should have a mammogram with possibly an ultrasound. I was just diagnosed with metastatic breast cancer, and it has spread to my bones. I have had every test and will be getting a biopsy on this Tuesday on my bone. It seems as though it's taking long to get a plan of treatment. How quickly should this be going? Because when you are talking about Black women not getting the same care it takes for our counterparts play a big role. About my plan, it's not being managed. Can you speak about this? Yes, so you should also have a care team. Your care team should consist of your oncologist, a nurse navigator, and a buddy, a person that you take with you on your appointments to help you navigate. So speak with a patient navigator to understand the plans that they are putting in place for you. Ask those questions. What are my plans? What are the time frames? And see if they can provide that information for you and to you. My mom passed away from breast cancer. Am I more likely to get breast cancer? Not necessarily, but you should have your a gene testing done to understand your risk of getting breast cancer. Does dense breast mean you're prone to breast cancer? Not necessarily. They're more fibrotic, and it just means you should pay more attention to your mammograms, your yearly mammograms, and your self-exams and ultrasounds. Dense breast cancer, dense breast is also associated with the more aggressive form of breast cancer, which is triple negative. Share Cancer Support has clinical trials information as a resource on their website. That is correct. And it's share, S-H-A-R-E, cancer, C-A-N-C-E-R, support.org. Hormone patches should be discontinued at what age? It depends on what age you started. Usually, if I'm not mistaken, do not quote me on this, usually you're taking them for 5 years. What is the digital mammogram necessary? It just gives a different view of the mammogram in terms of it being digital. It can help see areas that the one view mammogram doesn't. It's a little bit more in depth. To increase participation of minorities in clinical trials, I realize education is critical. However, are these incentives on grassroots personal approaches to recruiting minorities in these cancer clinical trials? So yes, education is important, but the initiatives are placing trials in areas where there are a diverse group of people, meaning diversity in terms of age, sex, race, and ethnicity. If at Pfizer, if we're doing a study where there's a diverse patient population, we are making every effort to place trials near people that need them most. And that, I think I have one more question. Nope, that's it. So those are all the questions that were submitted. Once again, I thank you for joining my session. And if there aren't any more questions, I will go ahead and end the session. I'll give it another 30 seconds to see if there are any more questions. There's a question that came in. When should your children be tested for the gene? My friend has breast cancer. The daughter is 19. When should she take the genetic test? I did attend a educational session before where there were genetic consuls there speaking, and the age I heard was at age 25 because the breast is still developing and the child is also still developing in terms of being premenopausal, meaning onset of menstruation and things like that. Can you mention the importance of screening for both survivors and general community while during the COVID pandemic? Yes, so they're still doing mammograms and ultrasounds during COVID. So for both survivors and for the general community, still schedule your mammograms. I know initially during COVID, there was some decrease in people wanting to go in to get their mammograms. So they're recommended that they're done every year. If it's a year and 3 months, I would still recommend you get it done. I actually got my mammogram done during COVID. I usually get mine done around my birthday. So this summer, around my birthday, I did double mask and I went in to have my mammogram done. Thank you for the comment on the information. The 30% stat that women diagnosed with breast cancer will become metastatic. Is that across the board? This is a staggering number. And what does the percent decrease after 5 years do, did you say? So, yeah, so the 30% is for early breast cancer. So that just means that there's a potential that those patients may become metastatic. What does the percent decrease after 5 years? I don't remember if I said there was a percent decrease after 5 years. I know it's lower. I think it was 19%. Again, thank you for the comments. Do you see a relationship between chronic deficiency of pre-hormones, vitamin D, and breast cancer among Black women? There has been studies done with vitamin D. I'm not too familiar with that data, so I don't want to incorrectly provide you information on that one. How do you get in touch with me? My email address is my first name, Janeen, period, Azare, at Pfizer.com. So when you look at my name again on the presentation, it's first name, period, last name, at Pfizer.com. To increase participation in minorities in clinical trials, I realize Okay, I think that is it. So again, thank you everyone for joining this session. I hope I addressed your questions. You're taking a few pearls away for this. I do have to put a caveat. I am a PhD, I'm not an MD. So any information I provided is to be followed up with your treating physicians. Thank you so much for joining the session. And please ask those hard questions. Bye-bye.